G'day and welcome back to the BroomeDocs podcast, and it is the first episode of 2025 and it is mid-January, so we're going to say g'day to Justin over in Toronto. How are you, buddy? Welcome to 2025 and joining us again on the podcast.
Yeah, another year older. It doesn't hit quite the same in your 40s as it does in other times, but that may just be me speaking through the North American flu season. Always comes right around this time as well, so it's there's a lot going on right now. But pleasure as always to be back with you. I would prefer to be in Perth doing this in person, but this is fine. This is good. This is fine.
Yep, it's I'm in the middle of summer. It's the opposite. It's we're having a heat wave at the moment, but we also have this bizarre outbreak of what sounds like a mycoplasma pneumonia running through the community as well. So all my family have been sick with that, so it feels like flu season, and I've managed to dodge it thus far. So must be my emergency department super immunity. I think there's something to be said about working in the ED. I think you build up a whole host of antibodies, which maybe see you through a few more viruses than the average punter in the community. Not sure.
Yeah, or you just get lucky. That was a weird one. We did the mycoplasma 6 months ago, so maybe it is just the summer thing. But like people were freaking out, and like it's just a self-limiting disease almost all the time. Anyway, you can throw antibiotics if you want, but like we went through this thing where like, there were all these rounds, and our pediatric hospital gave rounds, and they showed this spike in cases, but it was also a spike in testing that went along with the spike in cases, and you just don't know. And like everyone was trying to figure out what to do, and what you do is you do exactly what you always do. And if a pneumonia is going a little bit longer than you expect, then maybe you throw on some cover from some atypicals, and it didn't seem like that big a deal. But I don't know how we're dealing with it down in Australia, but it really, really freaked people out here for I'm not sure what reason.
Yeah, it sounds like a scary disease, doesn't it? Sort of similar to tuberculosis in its nomenclature, so maybe that's what bothers the people. Who knows? Cool. So what else is happening this year? So this is a big year. So this year we're hosting the Spring Sessions in Emergency Medicine Conference in Broome, and I've been co-opted into being the chairperson of that particular conference. So I believe that Dr. Morgenstern, you are going to be making an appearance virtually at the conference.
Yeah, unfortunately, probably can't fly all the way there this year, but I will be in the conference in one way or another, probably this format, and looking very much forward to it.
Yeah, well, luckily I have a slightly better Canadian who is attending in person, so Dr. Ken Milne.
Yeah, I mean, that's an upgrade, there's no doubt. But he'll probably have on a Canadian tuxedo of some sort as well. He likes to travel and with some really fancy glittery suits, so I'm excited to see what he shows up in.
Yeah. To be honest, you don't wear enough sequins to make the grade at my sort of conference, so that's what it's come down to. So Ken will be in Broome, which I'm really looking forward to. Probably wearing a sequin suit and sweating a lot. My guess will be it'll be great to see Ken in person. So if you're interested in coming to Broome and you're interested in sort of small hospital emergency department care and this sort of stuff that Justin and I talk about on the podcast, then check it out. It's the Spring Sessions in Emergency Medicine. On my blog, there's a link on the side, and I'll put a link in this show notes as well. It's basically the last day of September, the first few days of October this year, and it's the best time of year to be in Broome because all the tourists have left and it's nice and warm, so it's perfect. Cool. All right. Should we get on with some actual EBM?
Yeah, I mean, that is supposedly what we get together to do. So yeah, let's wade in. Cool. There's some interesting stuff this month. This one could have been saved for our last paper some months, but it gets the honor of being paper number one. I think another one sent to us by King Guthrie out of your department. He's been sending some great papers. The title of the paper is Airway Breathing Cellphone, a New Vital Sign, published this year in, I think, the International Journal of Emergency Medicine. And they basically try to answer the question, I think, I've never really had this sense where I work, and maybe we'll get into that in the paper. But the idea that, you get the patient, the one that I hear a lot where I work is if the patient's got their legs crossed in the room, then they can't be sick. There's no way. But this is the same idea. If they're scrolling on their cell phone, they can't possibly be sick. And so that's what they tried to test in this study. It was a pretty well done study, actually. So it's observational. It's really the only way you're going to be able to do this. But it was actually blinded. So neither the doctors nor the patients had any idea what was going on. And they used scribes who were in the department just to watch what was going on and record whether the patient was on the cell phone. They only did it at one exact moment in time, which was when the doctor walked into the room. And then they just followed up and saw whether the patients were admitted to hospital or not. And the numbers were pretty staggering. If you were on your cell phone, you were 94% chance that you were going to get discharged home. Only 64% of patients who were not on their cell phone got discharged home. So that's like an odds ratio of almost 9, statistically significant.
Yeah, that's huge.
That's impressive. I don't know, though. I mean, the one thing that jumps out at me, those two numbers, is that like that admission rate is pretty damn high. Like they're only sending home 64% of patients, even in the like higher risk group. There seems very, very high. I don't know. Like it was interesting, and Kane seemed excited about it when he sent it our way. Is this a thing that you could use in your practice clinically?
I certainly think that the use of the cell phone is like if you're a triage nurse in a big busy emergency department where you're seeing hundreds of patients per day. I think that sort of modern distraction of the cell phone, I think it's certainly biasing, and I think I can certainly see how our nursing colleagues sort of, when they have to sort of distract people from their phone to do their actual job at triage, would be very frustrating. And so I can sort of see maybe there's a bit of venom in this paper, and that nurses are trying to prove the point. But it's interesting. There's obviously, this is an observational study from a single center. I think it was the Mayo Clinic in Minnesota, and obviously there's so many confounders that are going on here, and the big one for me is age. Like if you look at the two groups, like the people in the cell phone group were 42 years on average, whereas the non-cell phone users were 14 years older than that on average. And that sort of goes with what you'd expect. So young people tend to be addicted to their phones, and middle-aged older people tend to not be so much addicted to their phones. Although having said that, Candy Crush is pretty big in the octogenarian set, I imagine. But that's one big confounder, is obviously age and technology. There's lots of different generational sort of social norms as to what is appropriate and isn't appropriate to be using your cell phone. And I think for my teenagers, like they can hold a full conversation whilst crushing Clash Royale on their phone. I don't know how much information they actually take in or give out that's useful, but they seem to be able to multitask. So it's possible that is a thing. The other point that you brought up in your blog post is that cell phone use is a pretty blunt sort of tool, and obviously there's different reasons people may be on their cell phones. And I've just mentioned that our family was all sick last week, and that was pretty much what got them through those hours of fevers and feeling pretty crappy, was sitting on their phones and playing Quirtle or whatever it is that they do in their spare time, and that's just a way to soak up. And a lot of people nowadays use their phone as a form of entertainment or distraction, so it may be a completely valid thing to do, but got to say that discrimination is much better than all the other observations that we use at triage. So if you look at respirate or oxygen saturation, they're all pretty weak when it comes to predicting what's going to happen to the patient. So who knows? Maybe it is the new vital sign. I'll have to see what Kane thinks when I see him at work later today.
So just turn them all away from triage. If you have your cell phone out, you're not welcome in our emergency department. Go home is the new rule. I feel like an idiot. I looked for age multiple times in the paper, and I missed that because if that demographic is there, like older people get admitted to hospital more often. Like that is like the most clear confounder. I had a bunch of other things that I like in my practice. I think the number one reason people are clinging to their phone is for translation, which I think to me is irrelevant to this question, but I guess it would depend on your department, your city, how much translation you need. The second most common reason for like a sicker patient is because we aren't cancer centers, but all the cancer centers have all their information online, and so they want to show me their notes, their information from their complex care. So both of those things actually point, I think, in the opposite direction of what the study is trying to show, as compared to the person who just like, I have had a few adult patients that for some reason just continue to scroll on TikTok, even though I'm in the room being like, hi, would you like to talk to me? So like it's just way too blunt, as you said. Like there's many, many different ways you could do this. I would be very worried if anybody actually used this in their clinical practice. Like I can't imagine, like that is a huge by the numbers discriminatory point, but like, like, what are you going to do? You're going to make a clinical decision because they had their cell phone. So I don't know. And the last time I was sick, 100%, the best thing for me, like the sickest I've ever been, I was glued to my phone because what you want to do is take your mind off the fact that you're about to vomit blood again or whatever it is. Like, that's what you're doing. Now, I haven't been admitted to hospital, so I'm not in this study. Like, I don't know. My guess is there's actually probably a U-shaped curve somewhere in here where, like, yeah, if you're really, you don't need to be in the emergency department. You're going to be on your cell phone. But if you're really sick, you might have more reason to try to distract yourself. So I don't know. It was an interesting paper, but I can't imagine that it has any actual clinical use. But I don't know. Prove us wrong. Put it in your comments how you would use this in real life.
Well, one of the cruel ironies is that in our current emergency department where Kane and I work together, they're rolling out a thing called the virtual emergency room where people actually put their basic stats and their symptoms into their phone, into an app, which then feeds up to the triage nurse. So, you're damned if you do or you're damned if you don't in that situation. The study I would like to see is the one where we could do a double crossover where we use sunglasses on indoors and using cell phone. So, like, if you're wearing your sunglasses, you've either got bad photophobia or you're just a jerk. But if you've got your sunglasses on and you're scrolling through TikTok at the same time, you're probably fine. That would be my guess.
Yeah, what you really need to do, and so if somebody wants to do endless follow-up studies, is what app is open on the phone when you walk in. Like, there's a big difference between TikTok and, like, I don't know, they're on the phone with a loved one to trying to get their last words in before they freaking die. Like, those are two very different uses of a cell phone. Before we get too morbid, I don't know if that may be all that we can really say about this paper.
All right, shall we move on to something a little more salty?
Yeah, nice segue.
Sorry, that was the worst. Worst segue ever.
The worst segue for other people's podcasts, but it's probably still in our top 10. Yeah.
So this next paper is all about the treatment of hyponatremia in the acute care setting. So this is correction rates and clinical outcomes in hospitalized adults with severe hyponatremia, a systematic review and meta-analysis. And this was in JAMA Internal Medicine November last year. And the lead author is Ayus. So what this was basically was a huge data dredge. So they went through and did a big systematic review, meta-analysis. They ended up with 16 studies with nearly 12,000 patients, so pretty big numbers. Ford is a pretty common presentation at the end of the day. And what they were trying to work out is, obviously a lot of this data is quite heterogeneous. There's some retrospective, some prospective data, but they were trying to work out what was the best speed at which you should be correcting sodium. So they divided the patients up into 4 groups based on what actually happened in the trials. So there was the very rapid, which was the group that got more than 12 millimole equivalent sodium increase in 24 hours on average. And then there was the rapid group, which was 8 to 10. The slow group was sort of 6 to 10-ish. And the very slow group was sort of 4 to 6 milliequivalents, which, as far as I can tell, is essentially doing nothing. Most people will improve their sodium if you just chuck them in hospital and don't let them drink from the tap. That'll work. And so they took this huge data set and then they tried to work out if there was a dose response curve between mortality outcomes depending on how you were treated in the emergency department or in the ward mostly, because let's be honest, most of these patients are not getting treated for more than the first hour or so in the ED. So this is usually an inpatient sort of thing. And bottom line is that the old-fashioned sort of rule that we're all told that had to go slow to avoid central pontine or other osmotic demyelination syndromes was actually not such a great idea, and that there was, a significant difference in the mortality curve. So in the rapid versus slow, it was 103. This is numbers out of per 10,000. There was a 32 per 10,000 difference in mortality favoring more rapid. And if you compared it to the very slow group, it was 221. So that's 2% mortality difference, which is pretty huge per 10,000 people. So obviously osmotic demyelination is something that we all worry about, but this was pretty rare. And I reviewed a paper with Ken a year or two ago now, the SALSA trial, and the same thing in that trial where basically it's such a rare phenomenon that even in the trial this huge, they only had a handful of cases. So it's really difficult to say much sensible about how common or how risky osmotic demyelination syndrome is, even when you're looking at a really huge data set like this, because like most of the groups had between 0 and 3 actual cases of that happening, which is pretty uncommon. So I guess my question for you, Justin, is do patients really care what they die of? And would they rather die of osmotic demyelination syndrome, or would they rather die of something else? We don't know what these patients died of course, because that wasn't something that was reported in this trial. So your thoughts?
Yeah, so I mean, I think for that question, it's not what they die of. I think that it's possible that demyelination is worse than death, and that's really the question.
Sure.
And then we go, although when you actually read through most of these case reports, like what actually happens is most patients get a bit of a headache for a few days and then it goes away. Like we always hear the case reports of the really, really bad demyelination, but the vast majority are they found something on MRI and like nothing happened to the patient. So that's point number one. I'll correct one thing about your numbers. It wasn't per 10,000, it was per 1,000 here. So we were talking about in the lower risk, it was an increase of 3%, and in the higher risk, it was an increase of 22% mortality. Like these are like very, very, very high. And to me, that's the biggest point. So we could start with the downside of this paper, which is it's all observational data, which means confounders are going to be really, really common. And they don't get into it in this paper, but I dug through a bunch of other like links and went through. And essentially, there's a much, much higher rate of sick patients in the slow groups. So that's patients with cirrhosis and known CHF and even like metastatic cancer. And I don't know whether they're harder to improve faster or whether patients or doctors just naturally go slower in patients with multiple comorbidities. But that right there could explain all the difference, right? If you have a metastatic cancer patient dying of their cancer, potentially not from the sodium. And so I think the downside of this, or the reason to not immediately act on this paper, is that confounders are highly likely to be at least some of this data. But the flip side, and I think we do this a lot in medicine, is we get really focused on the boogeyman and lose track of the larger patient. And the demyelination rate, it wasn't even statistically significant here, but it might have gone up. If you ignore statistics for a second, if you went really fast, the fastest they could have gone, it might have gone up by 2 cases per 1,000. So 2 cases per 1,000 is the risk of demyelination. 220 cases per 1,000 is the increased death. We're talking about 2 orders of magnitude difference in that same group, and I think we do that a lot. And I think that's the reason to pay attention to this paper, is that demyelination is the only thing that all of us have based our practice on. It hasn't been well thought out practice. It's not logical practice. It's not what is the best for the patient. We're afraid of one entity that essentially never exists and actually doesn't maybe have as bad outcomes across the board if you really read into it as you do, versus patients seem to be dying if we do this really, really slowly. That, to me, even though it's observational data and even though there's all sorts of problems, might hint at the fact that we actually should be doing a practice change until you can get an RCT. I don't know. It's when you have data like this, it's really, really tricky. You always have to base your practice on the best available data, and this is what we have. But I think, if these were close, if it was within an order of magnitude, I wouldn't know how to compare, 10 extra deaths to 5 extra demyelination events. Like those are close. And I would just say is observational. You got to throw it out. But when you're talking about 100 times more deaths than demyelination, I think you have to base your practice on the deaths. And so therefore, I think, I don't do a lot of this treatment, but I do start freaking out if I see that number going too quick. And I've been doing this DDAVB clamp and like slowing it down. And I've been taught all sorts of this crazy stuff. Apparently not. Just let them correct. I think is the correct answer most of the time. I'm still not being aggressive. Like you're not. Like most of the time, the answer is still you're supposed to do nothing, because the whole point is just stop giving them water in like the treatment of almost everybody. And if they're dehydrated, a little bit of a bolus. And these are elderly patients. I'm not like flooding them. So like it's hard to be aggressive. Like I don't know what you're doing to correct it all that fast. But I think the fact that the outcome is so much more common, it might be worth changing practice based on observational data. But I don't know. Like again, happy to have you tell me I'm an idiot for that. It's an interesting debate. I was hoping for more people to comment on my blog to sort of push me in one direction or the other, because it's hard to know what to do with data like this.
I think this is a classic case in medicine of that. We're much more scared of errors of commission rather than errors of omission. Yeah. And telling someone to fluid restrict to a liter for the next 24 hours, we happily write that in the chart every day of the week, whereas giving someone a 3% hypertonic saline bolus, that's an error of commission. And we think if we do that, then something bad happens to the patient, that's on us. Whereas fluid restricting the little old lady who's, is on a thiazide and drinks too much alcohol, that's probably something we feel good about. So I think that's part of the problem with the culture of medicine and this sort of thing. But I agree, when you see numbers like this, you really got to wonder whether we are actually doing the wrong thing. And obviously, you don't want to go too quick. And I think from an ED perspective, taking this data along with what I've learned from previous studies and looking at the SALSA trial, I think giving someone a single slug of a couple of mils per kilogram of 3% hypertonic saline is fine. And if you just do the one dose in the ED and then send them to the floor to get whatever the internal medicine folks are going to do for them and work up what else is going on, you're very unlikely to cause too many problems with a single dose of 3%. And if it gets them from that vomiting, headache, looking like crap to feeling a little bit better and their delirium starts to clear, that's great. So I think that's all we need to do as ED docs. But yeah, it's good to know what the data shows. And obviously, if you're working in an ICU or an inpatient medical ward, then you sort of, I think, can be a little bit happier to go a little bit quicker. And I think this data pretty clearly shows that doing nothing is probably the wrong thing to do at this point in history.
Yeah, which is often not what we're preaching. And I think you hit the point, although I have to think more deeply on it to know whether I really think it's omission versus commission exactly. But I think there's something really to this. And I think this paper, whether it's going to change your practice, I don't know. But really thinking about this broadly makes a lot of sense to me. There's a lot of things where we get caught up on one harm that may happen. Either we're going to cause it or we're not. But you think about contrasting kidneys. You think about that, it might put a patient on dialysis, but how many scans are delayed? How many other diagnoses are delayed? The whole department becomes inefficient because we're worried about this one tiny thing and we don't think about everything overall. We might maybe do a podcast in the future, or I'll bring it up. But the whole idea of keeping everybody fasting in the emergency department just because one might go to the operating room. We think about that one aspiration event, but we don't think about the harm of everybody getting dehydrated. And the reason in my mind is maybe not omission, commission is I start thinking about chest tubes, and I've changed my practice to the don't put in chest tubes at all in these spontaneous pneumothoraces, whereas a lot of people still do it. And the reason they do it, I think, is because they're worried about that rare, it doesn't happen event where the patient goes into tension and gets much, much, much worse without thinking about the overall patient, how comfortable it is to have a freaking piece of plastic in your chest. Yep. And is it really the best thing for the patient? So that it's not quite omission, commission, but we are worried about the things that can be pointed at us, where you deviate from standard care maybe a little bit. But when somebody can point a finger at you, I agree. It's scary if a bad outcome can be blamed on you. Whereas if you can just be like, yeah, it's just patients die. It's a little bit different. So I think getting a little bit more holistic with our view when we assess these risks and benefits, I think would be a good overall lesson to take from this paper.
That requires a lot of common sense thinking out of the big picture, which is not always our strong suit in ED. All right, let's move on to the next trial. And so just little warning for the listeners and viewers that if you're not interested in anything to do with tranexamic acid, just switch off for the next 20 or 30 minutes while Justin's head explodes quietly. And then we'll get back to some non-tranexamic acid-based papers. But he seems to have taken a real stance against lysergic acid and just wants to get rid of it altogether. So this first trial we're going to discuss is the Woman 2 trial. And if you haven't been following along the podcast or the blog, you'll know that we've covered pretty much all of the obstetric TXA trials, I think, in history. So we did the original Woman trial, Woman 2. I think I've covered TRAP 1 and TRAP 2. I don't know if you've covered them as well, Justin. And I think we've pretty much covered the full gamut. The only one that I hadn't covered in depth was the TXA MFMU trial, which we can talk a bit about today. So this is the Woman 2 trial, which is essentially done by the same group that did the Woman 1 trial. This is largely a trial of PPH. So I'll introduce the paper. The effect of tranexamic acid on postpartum bleeding in women with moderate to severe anemia, an international randomised double-blind placebo-controlled trial, published in Lancet in October 2024. Now, as with this group, they do amazing, huge trials in really difficult circumstances. So these trials are done in places like Nigeria, Kenya, Pakistan, India, all around the world, in a lot of places where the standard of care is very different to what we would be used to in the Western Hemisphere. And this particular trial, the original Woman trial, was looking at all comers essentially. This trial was focusing on women that have moderate to severe anemia, and the vast majority of these women would have been suffering with sort of chronic malnutrition or sickle cell disease or other things like that, which would have led them to be anemic prior to getting pregnant or before giving birth, which is a known risk factor for PPH. So they were looking at this sort of higher risk cohort to see if they could find the difference. And as is always the case with this group, a really huge trial, a really well done and conducted trial given the situation that it was done in. And their primary outcome that they were looking at was the incidence of clinical PPH of more than 500 mils. And to cut a long story short, there was no difference in any of the outcomes. If you look down the results table, it almost is a mirror image. If you look at the placebo and the tranexamic acid arms, there's pretty much no difference in any of the statistics. They're all so close together, it's ridiculous. The only thing I'll say before I take my leave and let Justin start ranting is that, as we've said, I think this was the same review of the original woman trial, is that this isn't really the group where we're expecting to see any benefit, if there is any, to TXA, because only 1.5% of the patients in this 15,000 woman cohort had a PPH of more than 1 litre. And so they're not really big PPHs that we're talking about here. We're talking about small PPHs. And what I'm really interested in is those women that have the massive PPH, and does TXA do any difference there? Because if you're going to see an effect, that's probably where you're going to see it. I don't think this trial can answer that for us. So, Justin, what did you think?
Yeah, the flip side to that, I agree entirely, is that there's a lot of argument that I'm not sure I believe, but that you should give TXA as early as possible, and the later is bad. And so I think that's part of the logic of giving it prophylactically. Postpartum hemorrhage is not emergency medicine most of the time. I've had a few, and it's really bad when you see it, but it's not core, and preventing PAPH is not that big a thing. But there's some of these topics, like at the end of the day, I don't really care if somebody throws some TXA at somebody. It's marginal either way, whether it goes. But it's a lot like people get in evidence-based medicine really got hung up on the Flomax for kidney stones or something like that. Who cares really one way or another? Except they're really, really good examples of evidence-based medicine and how crazy offline we get when people don't actually read the papers. Like, I've been at 4 conferences this year that had a talk on postpartum hemorrhage, and the segment on TXA was, it must be given as standard of care. It's been proven to save lives. And every trial has definitively been negative. There is zero change in mortality. It has been like, we have tens of thousands of patients in these trials. It's like the best studied thing in postpartum hemorrhage. And it definitively, for sure, does not save lives. Like, we know that. Now, it may save lives eventually if we find the right, if we only find people who are in the massive hemorrhage protocol, maybe it'll be beneficial. Like, if you want to break from the evidence in these outlying cases, that's not what we're saying. But they're saying everybody's got to get it because it's definitively proven. And that's crazy. And that's why you bring this paper up. The real reason I include this paper, like a negative, who cares? I think it's worth continuing talking about. But this is the first paper that I think really proves what every evidence-based medicine doctor has told you about TXA studies from CRASH 2 to Woman to CRASH 3, is that they are all massively underestimating the harm. They have to have been. And part of that is they're where they are. Like, you're more likely to miss PE in these settings. Like in CRASH 2, I think it was something like half the centers didn't even have a fax machine to enroll patients. Like, if you're working in that center, you probably aren't doing the same workup for everybody with a potential PE. But this study mathematically proves that they're not finding these cases. And the reason I say that, so I'm not sure we said it, but there's 15,000 patients in this trial, all immediately postpartum. And there was not, that they found, a single case of VTE, not one PE, not one DVT in the entire cohort. But we know baseline demographics say that the rate of DVT and PE is something like 10 per 10,000, 15 per 10,000. So in this study, there should have been 20. Now, I don't know that there were going to be difference between the two groups, but there had to have been PE. You can't have 15,000 postpartum women and not have a single PE. So to have zero, the only way to have zero is to have your eyes shut, or to be running your trial in a system that doesn't have your normal kind of workup that we do in North America. And I think it's really important to notice that in this trial, because it tells you that we're missing PE in CRASH 2. It tells you we're missing PE in CRASH 3. And we do see, every time they find it, it is doubled-ish when we see it. It was doubled in the halted, the GI bleed one. So it is almost certainly up. And it might be a lot more prevalent than what we're thinking, because we're just not finding it in these trials. So I think that's the most important one for this. Like we say it all the time. We say that RCTs are very bad at identifying harms, but you generally can have it proved so well. Like, you just can't have a trial this big with no VTE in the postpartum period. It doesn't make any sense.
Yep. And for those of you that are following along with this research, the Lancet also published a meta-analysis of all of the obstetric TXA trials, which was the ones I mentioned earlier, the woman trials, the TRAP trials, and the other one. So 53,000 women were included in that meta-analysis, and they actually went down and did individual sort of granular patient level data for most of those women. And the baseline rate of VTE in that was, I think it was 0.2%. So that's an order of magnitude below what you would expect to see just based on what we know about pregnant women in general. And, VTE is a thing. And it's really very, very low. So I completely agree. By definition, they're missing something. And that, like you say, it's probably not because they're poor at looking for things. It's probably because of the settings in which these trials were done. So I imagine it's pretty difficult following up women in rural Pakistan.
Yeah, and I mean, it's just part of it. It's very rare. Like you're trying to show that TXA works, so you don't want to add extra cost, extra work by what are you going to do? Bring everybody back and routinely ultrasound everybody? Like you can't do a CT on everybody, that would cause harm, but maybe you could ultrasound everybody. But now you're going to have false positives, so it is a little bit hard because but it's part of the differential because we actively look for our primary outcome, but we don't actively look for the harms. We just sort of let the harms come in. And because you're actively looking for one and passively looking for the other one, you're always going to have a lower rate of harms, which makes comparing harm to benefit really hard. I think that's the overall message is, you'll hear us gripe about it on the podcast all the time, but you have to sort of assume that harms are higher than we see in the trials, which means you really need to have good benefit for us to adopt new therapies. That's the only reason we say it. And I think this is a really good example is why.
Yeah. And I'm just going to say this, Justin, because I know I'll get hate mail from my anaesthetic colleagues if I don't, but I work as obstetric anaesthesia from time to time. And the woman who you've got who's having a cesarean and the surgeon's looking over the drape, looking really worried and sweating bullets because they can't get control of the bleeding, like we just throw the kitchen sink at those women. So don't use this research to say you're not going to give TXA to that woman if the surgeon's saying we need to do something, because I think in that group there's probably the data's not in, so you can do whatever you want, but whatever your institution is. But I wouldn't use this research to change what you do in an operating theatre in a crisis. And it may not have any benefit, but it's more likely than not to have a benefit in that group if given what we know at the moment, because we just don't have a lot. And I think most big centres now are using thromboelastic technology. And so if you've got someone that's got a TEG that clearly shows that they're thrombolytic, then, I think TXA is a reasonable thing to do. Having said that, that's still pretty rare even in the obstetric population. So we don't really know what the outcomes that we're looking for.
Yeah, I think if I had to guess, it's a lot like my argument for stroke for years is that we've just been looking in the wrong population. And my guess is that's the issue. We need a subset. But like, I don't know why we think TXA is part of that package, because since Crash 2, literally every single big TXA trial has been negative, like across the board. So like people latched on after Crash 2, like this is a miracle drug, and it does nothing in every trial that we do always. So the only caveat that I would throw, I 100% agree with you. If I had a patient dying in front of me, I'm going to give the TXA, as long as you're not doing it the old school, like infusion way, because you can do a lot of harm with neutral medications by tying up a line or getting distracted. And even just if like you have to choose which drug you're going to send the nurse for first. And if you're ending up grabbing TXA ahead of oxytocin, I think you're making a big mistake. I don't think anybody's doing that, but there is a prioritization. And I don't know actually, because we teach these things and now TXA has been given this like on a pedestal thing. So would I be surprised if a registrar grabbed and pushed TXA before they even thought about the oxytocin? Maybe. So I think that's why it is important to know, like know that you're doing something or know that TXA really has no role. And if you want to add it at the last, after your misoprostol, after everything else, sure, like whatever, I don't know, they're dying, like that's fine. But I think we've talked about this before in other contexts as well. I'm not sure the kitchen sink makes as much sense as a lot of people in medicine say it does, because we did the trial, I think it was the COCA trial, where they gave calcium to dead patients and they still had worse outcomes than they had. So, like you can still do harm with every medication has harms. And when somebody's dying out, just throwing things at them isn't necessarily a good thing. I'm not sure TXA is there. Like we as much as I say, I think we're underestimating the harms. It's not like there's going to be massive.
It's a pretty weak medicine.
We have. So like whatever. My guess is essentially the homeopathy of modern medicine. Like who the fuck cares? But I think I just lost us. Our YouTube rating is all gone. But it's like, we still got more TXA to talk about, so let's slam through this.
Yes. I was trying I was trying to think of an interesting segue from TXA to TXA, whereas I just keep going, Justin. So I will say this next trial. When I first read it, when you first sent it to me, I thought it was a trial about not overdiagnosing asymptomatic bacteriuria in geriatric patients because it's called the Stop MSU trial, which it sort of sounds like a prompt to stop sending off too many inappropriate urine investigations, but it's not. This is a tranexamic acid versus placebo in individuals with intracranial hemorrhage treated within 2 hours of symptom onset. The Stop MSU International Double-Blind Randomised Phase 2 clinical trial. This was in Lancet Neurology last June. And Justin, you've got some strong thoughts about this, but we've covered lots of trials in the past looking at the use of TXA for brain bleeds, and you've mentioned a few just now, the TITCH trials and so on. What's up with this paper? Why are we doing a 200 patient study when we've already got thousands of data points showing not much difference?
Yeah, I that's the thing. I really, really don't understand this trial, and maybe I should have emailed the authors to get a little bit more insight, but it's just so bizarre to me. Like, we have big phase 3 RCTs, and this is pitched as a phase 2, which is weird. And then, so this is a 5-country, 25-site double-blind RCT. Like, that is hard to put together. Like, the amount of work and the amount of money to get double-blinded, like, if open label is one thing, but also multiple countries, multiple IRBs. So 5 countries, 25 sites, and they enrolled 200 patients. Like, I don't understand. Now, they kept adjusting their enrollment goal, and so there may be some other stuff that happened behind the scenes, but it's just a very bizarre trial for that reason. Like, to me, this should be, at this point, like, we're beyond the point of a phase 2 trial. And definitely, if you're going to get 5 countries involved, like, get a reasonable number of patients. Anyway, they enrolled these patients who were adult patients with spontaneous intracerebral hemorrhage. GCS, I think, had to be above 8, not on anticoagulation. Yep. A TXA versus placebo, so placebo-controlled trial. The other big problem with this trial is they decided to use a surrogate outcome. They looked at the hematoma growth. And that is one of those things that 10 years ago, I might have argued with you as a reasonable surrogate, because there's a strong association between hematoma growth and bad outcomes in all of the observational literature. But we now have multiple trials in TXA and in other things where we see hematoma size growth, but the clinical outcomes are identical. So I think we've actually proven that hematoma growth doesn't actually matter at this point. Like, pretty definitively, it doesn't matter. But actually, it doesn't matter in this trial anyway, because there was no difference. So this is a big effort for only 200 patients to have a negative trial of something that we already knew, because we already had the TITCH2 trial with 2,300 patients telling us the exact same thing. So I'm not sure what this really added overall. But so I guess maybe when I'm saying that, maybe I shouldn't have included it. Maybe one of our readers can tell us why this would have been a phase 2 trial, or fill me in on some of the questions. Because I think that's my big thing. I was start looking at this, and I really don't understand how it got to where it was as a trial. Maybe still an important question to ask, but I don't know.
Yeah. But like I say, it's a huge effort. They've got Australia, Finland, Taiwan, Vietnam, and New Zealand. So 5 different languages. That's what I'm counting right there.
New Zealand and Australia are different? Is that what you're saying?
Yes. Yeah.
I don't understand. I can barely understand you. I lived in New Zealand for a while, so it makes sense. And Google Live Translate.
And yeah, as you say, if you're going to go to the trouble of designing this trial, like, they actually counted the modified Rankin score, and it actually looked worse in the TXA group. Not that it was statistically significant, but that's actually the outcome that we usually look for in these, like, patient-orientated outcome that we usually look for in these trials of brain problems. And yeah, there's actually looked a little bit worse if you look at all comers. And so it's quite bizarre that, obviously, it's more objective, obviously, if you use something like growth of the hematoma. Can we coin the phrase RU? Because we've got LUs and POOs. A RU is a radiologically orientated outcome. So just as an Australian, I'd like to put RU out there as like a bad thing. Yeah, we don't shoot the RUs, get rid of the RUs. The other interesting thing,
the rest of the world loves them so much. I don't know what your problem is.
They're very tasty. I think it's us.
They're not even. I've had a number. They're not that tasty, but it's okay.
They did use a mobile stroke unit, which was quite interesting. So that was all very sexy, sort of probably around the time that this trial was getting set up as well. So the idea was that you use the mobile stroke unit, you diagnose the bleed early, you get the TXA in as soon as possible. And so in this trial, they actually got the TXA in really early. It was around the 1 hour mark on average, which is pretty good for sort of a pre-hospital trial. So if that idea that TXA works better if you give it early, this is the best evidence you're going to see for that, because no one's going to get it much better. And obviously it still didn't make any difference. So, and just while we're counting DVTs, I'll point out that in this trial, it's only 200 patients, but the major thrombosis rate was 1% versus 3%. So maybe they did actually follow them up nicely and scan them and found a few more DVTs and PEs. Yep. But that's probably in the wheelhouse of what you'd expect for someone that's had a brain bleed and spent time in ICU, somewhere in that wheelhouse. So not statistically significant, but there was a signal. Okay, cool. Have we done enough TXA, mate?
Yeah, put a mark on the YouTube video here. People who are sick of TXA can jump back in at this mark wherever we are, and we'll move on. This next paper I found fascinating, but I only threw it in. I believe it's the podcast that Ken's is named after. I think he's the Skeptic's Guide to Emergency Medicine because of the Skeptic's Guide to the Universe, which is another just sort of general skepticism thing. So that they discussed this paper on theirs and just took it entirely at face value. And their conclusion was, "Oh my God, EpiPens don't work. That's really fascinating research." And I said, "That's weird. EpiPens don't work." And so dug it into myself, and I don't think I quite agree. But the paper was published a couple of years ago. Just 2024. I lied. Early in the year, 2024, in Clinical and Experimental Allergy, I believe, entitled "Adrenaline Autoinjectors for Preventing Fatal Anaphylaxis." And it's an interesting paper. It's got a lot of information in it. There's not a single clinical trial of epinephrine in humans. So it doesn't have RCTs or anything like that. So they include demographic data, animal studies, pharmacokinetics. I can't say that right now. Yeah, just a bunch of everything.
Heaps of physiology.
And the underlying concern, their sort of entire premise or entire thesis seems to be that the rate of anaphylaxis has gone up dramatically over the last few decades. Auto-injector prescriptions have gone up dramatically over the decades, i.e. we're getting to more people. We're getting them the EpiPen and they're getting it in their hand, but mortality has remained exactly flat, i.e. the EpiPens don't seem to be helping anybody at all, is their argument. But that exact same graph we've discussed before in a paper on overdiagnosis. And so basically what they're describing is overdiagnosis. More people are being diagnosed with anaphylaxis, which is more borderline anaphylaxis. It's not the severe anaphylaxis of the 80s. It's the, maybe their throat itched a little bit. You should have an EpiPen because that's what we do now. So I think their entire premise is based on just a misunderstanding of basic overdiagnosis. And then they dig into a bunch of stuff. They say, you can look at some, like the anesthesia data is probably the best because the anaphylaxis happens right while the patient's on an art line and you can see everything that happens. And, they have some data that says that, the hemodynamics of epi is not all that dramatic. You maybe see a bit of a heart rate bump, but you don't actually see a really good, blood pressure response. But out of everything else that they present, and you can tell me what else you saw in this paper, the only thing that really jumped out at me is they talk about a case control study looking at matched cases, people who died from anaphylaxis to patients who didn't. And everybody who died didn't receive pre-hospital epinephrine, and everybody who survived did. And they still get on to doing like the thing. Now, again, that doesn't tell you a whole bunch, but like that piece of data really does not seem to go with their whole argument that auto-injectors and IM epinephrine are just this really bad idea. Now, should we pay more attention to this? I don't know. In a hospital, almost all of us, I think, are using 0.5. And so the fact that auto-injectors are still at 0.3, maybe they're a little underdosed. Maybe patients should have more than one in case they're not getting better. I mean, there's things that you could look at this data and maybe get into. And so that's why I thought it was interesting to include. And so maybe I'll shut up and just let you tell me what you thought of this data.
Well, the obvious metaphor here is the CTPA rates as well. So, like in the last 20 years, we've done a lot more CTPAs, we've diagnosed a lot more PEs, but the mortality from PE hasn't changed, and that's not because anticoagulation doesn't work. That's because the patients were never going to die of those tiny PEs that we were picking up on inappropriately ordered CTPAs. And so it's the same thing if you diagnose, the kid with the mild rash and give them an EpiPen, because we're all very worried about missing that opportunity to save a life. But I'm sure there's millions of kids out there in the world that have EpiPens that probably never get used and are often used probably for pretty mild symptoms, where we wouldn't, if they were sitting in the ED, we would just sit on them and watch them for an hour or two and see what happens. So I think you've completely nailed the brief there. That's what's going on here, and it is interesting though. Like the use of IM epinephrine. Like I've certainly been through a process in the past with people with severe anaphylaxis who have not used the EpiPen either because it was out of stock or it was unavailable, and they've gotten really, really sick, and then they come to the hospital and we give them intravenous epinephrine. And I've been criticized in the past for not using IM in that setting. And I think it's very interesting, because I think the reflex of all emergency physicians that I've ever worked with is just give the IM and then get a drip in and do whatever else is that you need to do. So it's certainly become part of the culture that we use it. But like you say, there's just no evidence that IM dose in particular is useful for those patients at the more mild to moderate end of the spectrum. And if you're working in a big emergency department and you have access to people that can get a line in quickly, I think we're all pretty comfortable nowadays with push dose epinephrine, and I think it works as well. So not really an ED specific paper, but it's interesting, I think, more for the GPs and the people out there that are prescribing EpiPens to kids or to people with allergies, just thinking about, what is your threshold for prescribing these things, and are we really doing more harm than good? But I don't think this paper tells us anything about the efficacy of EpiPens for people who have proper anaphylaxis that can die quite quickly.
Yeah, honestly, I think this might be more ED than almost anything else, because I think we probably start the label on more people than anybody else, because they come to us, not the department, and we probably start their therapy. And so I think there are a couple questions that are reasonable that come out of this. In the future, it's possible that a 0.5 is better than a 0.3 dose, but these things are, this is the overall issue here, is these auto injectors were invented on using public funds by the military back in the 50s. The fact that the drug companies have patents on them and charge hundreds of dollars and just escalating prices is insane. I don't want to go to 0.5 because it would give them another excuse to freaking patent the goddamn thing. So that is a different thing. But clinically speaking, it either might be higher, or in the meantime, does it make sense for somebody who, like, there's the whatever, have the EpiPen because maybe this was anaphylaxis, but I've had the few that are like, you almost died. Should you carry around 2 EpiPens so you can give it back to back if you're really sick in the field? That's one question. And the thing in the paper that they imply, which I'm worried about, is that in the hospital, we should just go straight to IV. And I think that is a mistake, but it's only a mistake because we treat so much borderline anaphylaxis as an anaphylaxis, right? That like, the kid vomited once and there are some hives, and like maybe he says his throat's a little bit scratchy, but like all of his vital signs are normal. If you rush straight to IV there, you're going to cause dramatic harm. In my career, sure, I've been in 2 different pediatric VTAC cases that were 100% from the IV dose being wrong. Flip side is I've been in 2 cases in the last year where the patient was, I heard doctors stat to resus, 3 doctors were already looking after this patient, known anaphylaxis, blood pressure's in the tank, stridor, they can't get any air in and out, like SAT's in the tank, and they've already had 3 IM epis, and I just grabbed crash card epi and gave 100 mics straight into the IV while they were like, they were getting ready to intubate and do other stuff, and within 45 seconds, they turn the corner. So there are patients where the IM is just not getting through. And I think some people get a little bit stuck on that. And so if you come in sick, if you come in at least bit hypotensive, I'll go straight to IV. If you're in my resuscitation room, I'll go IV. Most of the anaphylaxis I'm seeing is like starting in the chair somewhere and we're moving them over. I'm sticking with the IM in those patients. I think that was maybe my long-winded way of saying the exact same thing you said.
Oh, yeah. And I think I think what we really need, and the future of research for anaphylaxis for this problem, is we need a way of risk stratifying patients. And like in my head, I've got this sort of vague risk stratification of how severe their symptoms were, and then also their background risk, like if they've got uncontrolled asthma or whatever. And then those are people that I'm more worried about. Whereas I don't think we're there yet. And I don't know, Justin, maybe we need a clinical decision aid to help us make this diagnosis and work out who needs an EpiPen and who doesn't. But there needs to be some sort of process that we go through. And like in Australia, that's mainly done, like people get referred to an outpatient immunologist who takes the history and goes through and does some tests and works out who needs an EpiPen and who doesn't. But that threshold is pretty low still, even in Australia and New Zealand.
Yeah, and even for the ones that we give in the emergency department, I don't know if you've had any different experience, but for me, every ICU anaphylaxis and the few deaths that I've seen they all happened within the first 3 minutes. I've never had a patient who showed up maybe as anaphylaxis and got worse over the next couple hours in the emergency department. That just never happens. If they die, the story is always the family feels really guilty because they were a little bit late giving the IM epi in the field, but they were like dead on the way to the hospital. It seems to be that rapid a disease, and so I think we freaked ourselves out a little bit. That they might get worse in front of ourselves, and I don't think that happens. But I don't know. A single doctor's experience can't necessarily label that, and so I don't know. There's one other factoid just for our nerdiness that I thought I would throw in there. I noticed in the introduction that they say that anaphylaxis affects 5% of Americans, which seems really high just to say 5%, 0.5% in Europe. So there's a 10x difference between Europe and America. Is that overdiagnosis, or is there environmental, genetic? Is it a real difference? Any thoughts on a 10x difference across the pond?
I imagine... This is just my biased guessing, but I imagine it has a lot to do with the American healthcare system and don't just stand there, do something sort of mentality where I think, and particularly with the medico-legal side of things in the US, is that if you don't send someone home with an EpiPen, you're leaving yourself open to a lot of criticism, whereas I feel pretty comfortable sometimes with those mild to moderate cases, just sending them to a clinic without an EpiPen in their hand. So, it's a tricky one, but I think in the US that would be seen as negligent practice if we didn't just send them home with an EpiPen. Yep.
Yeah, I think that's cool. That's probably the right answer. So next paper, you're going to give us some profound thoughts. I'm going to let you take the lead because you already have a video up. You got blog posts, you read all over this. So some profound thoughts on Profundus, please.
Yeah, so I originally heard about this trial through the MCRIT podcast. So Scott included it on his rapid literature review a couple of months back. And so this study, just so that everyone can follow, is the diagnosis of acute aortic syndromes with ultrasound and D-JAMA, the Profundus study. And if you are really, really bored, you can go onto my YouTube channel or go back to the blog site and watch a 27-minute rant, which I go through the deep dive and rearrange all the statistics to make them more user-friendly. I don't know, Justin, did you have a chance to watch 27? That yet?
Oh, I watched it all the way through. Absolutely. It's fantastic. Okay. I just don't know if you're going to be 27 minutes. I have the timer going. I'm going to see if you get through it now. It's good.
All right, I'm going to try and do this quickly. So, essentially, this is a multinational trial that was mainly done in sort of Italy, but there were some other sites around the world. I think in Southeast Asia and Brazil, from memory. A multinational trial which looked at a 3-pronged diagnostic protocol in the emergency department for adults that with suspected acute aortic syndromes. And for those of you that aren't up with the lingo, an acute aortic syndrome is basically a dissection, like the vast majority of these were type A dissections, but there were also a few that had a thing called a penetrating atherosclerotic ulcer or an intramural hematoma, which is essentially the same disease, but just at a milder end of the spectrum. And often those ones don't need an urgent operation, but the vast majority were type A dissections. This is a really big trial, so 1,979 patients, and at the end of the day, 9% of them were ruled in with some sort of acute aortic syndrome. So, this isn't a rare disease. 9% is pretty high for this population. We definitely don't see 9% of acute aortic syndromes in the patients we work up in my ED. It's probably more like 1 or 2%. So maybe I'm more American than the Europeans. The three things that they use the thing called the ADD score, which is a clinical decision tool, which is designed by actually one of the authors of this paper was actually one of the lead designers of the ADD score. So that's a validated sort of decision tool looking at basically clinical signs and examination and history signs, which you get points for the various things, and you can look up the score on MD Calc. To my mind, basically the ADD score is pretty much what you should know when you graduate medical school in terms of working up a patient for dissection. So family history, severe tearing pain going through to your back, pulse differential, anything like that, which would make you think this isn't your standard chest pain. This is something else going on. So you can use the ADD score. You can just use common sense. I think they would probably work about the same. And then every patient in this cohort, so all of the patients that presented who had a meaningful where dissection was a meaningful consideration, and that's a very wishy-washy sort of inclusion criteria, unfortunately, got this advanced echo. And this wasn't a quick look. This wasn't just Justin throwing the probe on and going, oh yeah, that looks like a dissection, or that aorta looks a bit funky. They actually did quite a lot of views, including suprasternal views, which are definitely not something that we teach on the average weekend course. Like, that's something that really requires expert providers, and these were expert providers. So these weren't people that had just done a few courses or had a tinker. These were people that had actually been trained pretty well in how to do echo. And a lot of the signs they were looking for required measurement. And when you teach echo, measuring things is particularly fraught. So I think we need to take that with a grain of sand as well. And then the patients that were in the low-risk cohort, so they had an ADD score of 0 or 1, and then they got their echo, which didn't show any hard signs or no soft signs even of dissection. They then got on to a D-dimer, which they used an age-adjusted D-dimer, which was good. And the ones that had a negative dimer were essentially sent home. And the primary outcome was the safety of their protocol. And the good news is that basically in all the patients that were in the low-risk pretest probability and then had a negative D-dimer, I think there's nearly 1,600 patients in that cohort, and they had 0% misses, if you believe statistics. Obviously, the 95th confidence interval went up to about 1 in 240 something, and I think that's an acceptable miss rate for this disease, given that we know that our acceptable miss rate based on our current practice is probably like 30 or 40%. I think that's pretty much the standard of care in emergency, is to miss dissection once or twice in your career.
Well, we are mixing two different numbers there, and I think it's really important, right? Because it's it's really, really rare that we miss an aortic dissection of all the patients where it pops into your brain. But of the people with actual aortic dissection, yes, we'll miss a few, and so that makes it a little bit tricky. And I think to me, it's the biggest problem with this paper and all papers, the ADD score, everything on aortic dissection is, as far as I can tell, nobody's ever done the test threshold calculation. Nobody's actually gone out and said, here's our current imaging rate and here's what it should be. And if you don't have a target in mind, you have nothing against which to judge these scores. And that is a big, big, big problem, because aortic dissection might be one of those things that we should be imaging dramatically more. Like most of the time in PE and everything else, when they come up with these scores, they're trying to get us to scale back on our CT use. And it doesn't work. These scores never decrease imaging. They always increase imaging. But maybe aortic dissection, we should be increasing imaging. Sure. That might make perfect sense. But I just don't know. And if we are trying to increase imaging, by how much? It's not the problem. There's a big problem, but that we just don't know what our target is. And therefore, whatever numbers they throw at you, is it good? Is it bad? You just don't have a gold standard against which to compare it, which is a bit of a problem. Aside from the gold standard we do know we have, which is current clinical judgment, which they don't compare against, and the ADD score doesn't. Like, nobody compares to just a good doctor. That doesn't happen, right?
Yep. Although of all the decision tools I've ever read, the ADD score is basically the most commonsensical decision tool. Like it basically is just common sense written down on a piece of paper. Like it's pretty hard to do worse than the ADD score, I would think.
I mean, when you actually take a step back, I think I had this rant about the PCAR and C-spine rule, but almost all of them are pretty freaking dumb. Like the auto ankle rule, it's like, does it hurt when you touch bone? Can patient walk on it? It's not broken. Did you need a rule to say that either it hurts when you touch the bone or they can walk on it? They're like most of the rules. The rules would be great if they caught things we weren't thinking about. Lupus as a risk factor for acute coronary syndrome or things like that. But yeah, the problem is they all use this. They the simple things, and they're right there in front of our face, which is why essentially all the rules continue to fail. I don't know where I cut you off in your summary of this paper, because there's probably a lot more that we could say. They claim a really, really high sensitivity, but don't really tell us what it's going to do other than that. And you can't run a study only to say it's going to rule out. What I found fascinating, it's amazing to me that they got to the 9% rule-in rate, as you say. First of all, I don't know how you do that. Like in my practice, I do let myself be pretty liberal. I'll order a CT of the aorta at a relatively high rate. I think I might be lower than you, but yeah, I'm probably 2% in my life for getting these correct. But like their inclusion criteria were any patient who had thoracic, back, abdominal pain, syncope, or any organ perfusion deficit, which could include just kidney failure, within 14 days.
Yep.
Like 97% of emergency department patients could, like, they obviously were way more selective than their inclusion criteria said. But if you applied this rule lets you rule out only about 48% of patients. 52% of patients required imaging by their things. So if you went by their inclusion criteria, everybody needs CT scans. I think if I applied this as written on paper, not as they were doing it, because the Europeans seem to be way better than me, but if I did it as written on paper, I would have to scan like 6 extra patients a shift. That is, and maybe I should be scanning more. I don't know what my miss rate is, but that seems like a lot to me. Like it just does.
Yeah. And I think that's one of the other points I bring up, is that the European sort of milieu is very different for these diseases than the American or the Australian milieu, and 9%, like you say, and even in their high risk group, it was like 40% ruled in. So nearly half of the patients in the high risk. So they're really proper high risk people. So that's most of us would get a little bit nervous about even contemplating not scanning those people. And like you say, the inclusion criteria were very broad, and the actual inclusion criteria were so vague that this would result in, if I'm the guy on the floor doing the echo, which I'm going in an hour or two to work, I would just be echoing people all day long, because every patient with chest pain would need an echo, like urgently, stat right there. And we discussed this at our group, and this is something that's just crazy. Like you can't be doing this. So I think that's one of the problems of this trial, is it's really echo heavy, and like you say, they estimated that they would reduce their scanning rate by 40%, their CT scanning or MRI scanning, which sounds great, but maybe they're starting out at a too high level. But my guess is that they're probably not, because if they're 9% rule-in rate, they're very brave if they're going to drop their scanning rate by another 40% based on this. So interesting. There are a few other problems with this trial, Justin, and I'll just quickly mention them. One is that, well, you'd end up doing a lot of echoes. The echo images that they used in this trial, they didn't actually record them or keep clips. So there was no QI and there was no inter-observer reliability assessment. And I'm sorry, but if you're doing an international trial that is focused on echo, and there's this very specific echo criteria that you're trying to meet, you need to record those clips, and you need to have them QI'd by 2 or 3 other observers, because we know that we're not very good at this. And they say in the paper that, there's a really high observer reliability, but only for one of the measurements, which was aortic diameter, whereas a lot of the other things they're measuring, like, the thickness of the aortic wall being 3 versus 5 millimeters, like that's really subtle. And the telltale feature of this is that 1.5% of the patients who they definitely saw a flap on their echo turned out not to have a flap when they went on and got their CT. So, like, echo is far from perfect. And we know from all the other literature around echo that there's a huge inter-observer discordance. So they should have done that so that we could actually get some useful data about how good are we really. And at the end of the day, like, I echo people all the time, and I reckon about 20% of the time I write in the notes inadequate views to exclude X, Y, and Z. And that didn't happen at all in this paper. And I think that's the reality of practices. If you're echoing 100 people in a day, which you would be, 20 or 30%, you're going to walk away saying, I don't know, just chuck them in the CT because I didn't see it. And that would have been really useful data to get out of this trial as well. Do these expert level people miss things or not get adequate views? So I think in an ideal world where you had experts that got every view and could measure everything and they were perfectly just corresponding with one another, this looks like a great protocol, but I don't think that's reality, and I don't think you can translate that into any emergency department that I've ever worked in. And I work in an emergency department with, some of the most highly trained echo ED providers in the world, probably. I've got Rippy and people that are smarter than Rippy at echo at the bedside. and we're still missing, we're still not able to get good views on all of them. So we often still scratch our heads. So I think it looks great on paper, but I don't think it translates into reality at this point in history.
Yeah, I think there's a lot of really good, I can get into the details on this. I maybe am biased. The very first journal jam I did for EM cases was with Rory Spiegel on D-dimer for aortic dissection. You can go back and look at that if anybody wants some details, but it just doesn't look good. And so now we're trying to add it to a bunch of other stuff. It's all the same issues. I think one of the big things, and we do this in a lot of topics, is we run these rules and we include everybody. I don't need help in about half of aortic dissection patients because they come in and say, I had this tearing pain and now my arm's dead. That was my last aortic dissection. I'm like, I know what you got. They were on a high dose labetalol drip. They were going up. The CT wasn't really necessary. I got it because, it is what it is. And half of the aortic dissections I've seen have been that obvious. They walked in and said, I read this textbook and here is what I have. The other ones, though, are freaking weird. Yeah. And I'm always afraid to tell people the story, and it is a family member of sorts. But literally, the only symptom was 4 months of night sweats. And eventually his GP was like, shit, we're just getting a contrast CT because you might have abscess, cancer, lymphoma, whatever. Freaking dissection from his coronaries all the way through his iliacs, went to the freaking table that day. The only symptom was night sweats. And so... And I think everybody has seen cases like that. And the problem with these rules is they include everybody, which inflates the look of the rule because they're like, oh, we caught the guy with the tearing pain and it went into his arm. But are you going to apply this rule to the guy who shows up to the emergency department with night sweats? No, but that's an extreme case, which still blows my mind. But most of these patients are too subtle, and most of these patients come in with a presentation that I also see 600 times that month, and none of the other ones are aortic dissection. And so what you need is a rule that only applies to the ones that are competent. You have to, at the beginning of your study, exclude everybody. You have to ask the doctor, do you think this is aortic dissection? If yes, they're out of the study because I don't need a rule in those patients. They've already made up their mind, and it can only be in the other patients. And I can essentially guarantee you the rule is going to fail because these patients, I think, are too complex. Maybe not, or maybe there's some other biomarker or maybe something else, but you have to do the research there. And otherwise we are going to continuously fail. And my guess is we're never going to get there. My guess is you have to rely on clinical judgment. I listen to the same thing that Weingart, and he seems really up on it. He wants this to work. And I think it's the American thing. They want to be able to just put something on the chart and say, this is done. But goddamn, guys, we're doctors. Sometimes you just got to make decisions and things are going to be difficult. And unless somebody can really come up with a different biomarker for this, we're just never, ever going to get there. And I think that is essential when you look at this paper for all things.
I think a couple of counterpoints to that. One thing that did come out of this paper was that if you put the probe on and you see a flap, in that sort of patient that comes in, you described chest pain, numb arm, you put the probe on, you see a flap, they cut their time to getting definitive imaging from 2 hours to 1 hour. And to be honest, if I'm seeing a flap, I'm just calling the cardiothoracic surgeons and saying you need to free up an operating theatre and we'll push them around to CT and bump all the other CT patients out of the way. So I think that is something that does correlate with my practice and all the people that I've had saves with these sorts of dissections or peripheral vascular disasters. It's where we've seen it on a bedside scan and just cleared the decks. And I think that's a really useful thing because those patients can die in the ED. And quite a number of their patients did actually die in the ED in the study, the ones that actually died. So I think that's particularly useful. The other thing that I would say is that I think there's two different echoes here. There's that quick echo where you just put it on. I'm pretty convinced that they've got a dissection. I'm doing the echo so that I can call the cardiothoracics with some sort of objective information and say, yep, there's a flap, we're going. And that usually works quite well. And then the other echo was the one, like you say, there's all these patients with bizarre chest vague symptoms. And what I really want to know from this is how often did the echo actually find the big PE that was not clinically pickable because it showed right ventricular stain? Is it actually a useful thing to do? And I want to know if my bedside echoes, which I don't do to make a rule in dissection, I'm just doing it because it's a chest pain that's really undifferentiated. Is it useful? And I think they could have given us that data from this trial as well. They could have said, well, this is what we found on all the non-dissection patients, which would have been really useful data, at least so we know what we're not missing.
Yeah, that's the echo point. And then the other half of that point is people get so focused. They wanted 100% sensitivity here, but by not thinking about all the other diagnoses, I mean, a lot of the time, if you do a dissection scan, you'll pick up a PE if it's a really big one, but it's not the right scan. And so did they do this and have a false positive aorta, scan the aorta's done, and now did they stop? How many times did they miss PE, or did they do 2 contrast scans back to back? Did they go back and look at the PE? Some radiologists will do that triple scan for you. Some won't. So like there's a lot of harm by being really focused on one diagnosis at the expense of the others. And I think, a major downfall of this paper, not the overall strategy, but of this paper, is not giving us those details on, there must have been PEs in this cohort for sure. Like that is one of the common presentations. And what happened to them? I don't know. Did it improve the rate of diagnosis? Or did it make it worse? Like, who knows?
It is fascinating. And probably the last thing I'd say is that even in this protocol trial, like there was still a pretty significant number. It was in the teens of patients that didn't get a definitive imaging at their primary visit. Even the high risk ones didn't get an imaging in their first visit, which maybe they're just super relaxed in Italy or wherever they were going, but most of these patients are not leaving the hospital till they get a scan. If they've got soft signs on an echo, for example, they're definitely getting a scan before they go home. But these were being followed up in outpatient clinics, which is pretty amazing. So I think this is a very different world that we're talking about when we're talking about our patients versus what's going on in this trial.
Yeah, I scan everybody. The only distinction, there's a small percentage of query aortas that go straight to the scanner that I actually get on the phone and fight. And this is a stat case, they're going. And then there's a bunch of these ones that they end up getting their scan 6 hours later because there's a long line. But they're like, I don't know. Yeah, they said that their arm felt numb for a little bit and then their leg and maybe it's migratory. But it's I have to do it. But I'm not kicking other patients off the scan. And that is one of those things. You have to put the patient in the context of the entire department. I guess some of those weird ones, maybe they are sending them to follow up because I really don't think it's aortic dissection, but I have to prove that it's not. And so maybe somebody could follow those up. And I think a CT is still a brilliant tool in general. We don't have to be that perfect to get our rate below 9%. Way to go, Europe. That's pretty
cool. All right, enough about dissections. Let's talk quickly about decision rules, because it's something you're pretty passionate about, and you found someone that agrees with you, Ed Carlton.
Well, I dug back 5 years, and so seeing as they were saying the same things I am, there's a lot of, I get to pick the papers.
Oh, so they thought of it first before you.
I finally learned where I get all my ideas. I just go back. I actually think that they are not strong enough in what they say in this paper. The paper is by Weber in the Emergency Medicine Journal 2019, Side Effects of Decision Rules or the Law of Unintended Consequences. So a reasonable title. And all that they are saying is that our primary goal with these rules is avoiding or misdiagnoses. And so the researchers often get really focused on that sensitivity at the cost of specificity. That's really what they talk about a lot. The example they give is actually really funny. One of the examples they give is, everybody feels compelled to order CT scans in patients who hit their head and are anticoagulated. And they think that we're way overdoing that because those patients fall outside of rules. And the only reason that we're doing that is because of rules. And I'm not sure that's the example I would have picked. But the idea is that the rules are increasing testing overall without benefits because they make us comfortable. And I think the better example, is just the CT scan head rule. Every patient 65 and older now is getting CT scans of their head, which is not what the rule exactly said, but you can't judge the rule without judging what happens with the rule or the unintended consequences that they're talking about. These rules aren't used in the isolated way they're designed in the perfect setting. They're used in real life. And the big problem is not the rule population often, it's the people the rule leaves out or who don't quite fit the rule, and that people feel compelled like they have to do something when they never would have before. And I think that's a large part of what I've been arguing. I think there's a lot more problems than that. But essentially they say that the absence of evidence should not trigger an immediate non-evidence-based recommendation to fill that gap. Is they're quoted at the bottom. We should use experience, a bit of Gestalt. I think that's reasonable. I think it's a good, I just wrote in it because it's a good essay to sort of think about the fact, we've said it a couple times today, right? Very frequently we get really focused. It's exactly like our first paper. We get really focused on not missing X. We want a sensitivity of 100% without thinking about what it does both broadly to that patient with his increased testing, but also to the system, to slowing down efficiency. Like, we just don't take a broad view enough in medicine. And I think a lot of the times we're causing harm, not because of that. Like, yeah, we really, really don't want to miss aortic dissection. True. But we also don't want this 100 extra people on the scanner so that the stroke can't get on the scanner, or so that the perf can't get on the scanner. And we don't take those considerations. We're always focused way too much on 100% sensitivity for the one thing in front of us.
Yep. I'm not going to say anything more, Justin, because I think we've covered decision rules and I think your position is pretty clear, and I think this reinforces that. Maybe the English are just a little bit more mild-mannered in the way that they put it across, but yeah, completely agree.
Everybody's more mild-mannered than me. I think that's the problem. I should learn something at some point, but I don't know, whatever.
Yes, it's worth a quick read, or if it's one of those ones that you could print out and leave on the tea table in your coffee room, and if a few people pick it up and have a read, it's a nice quick read. So yeah, definitely one that I would. This is our print out of the month and leave on the tea break coffee table. Cool. Shall we move on to the next paper, which is my reading of this, Justin, is that I've never actually ordered a procalcitonin in my life. Not once, not ever. So my understanding is that if I start measuring procalcitonins, I'm allowed to kill up to 5% more people in my practices. Have I got that backwards? Or is that
definitively what the experts are telling you? Yes. I think there's a very clear theme to this month, which is papers that aren't actually all that relevant to emergency medicine, but that have broader themes or broader lessons. And I think that's what this one is. I think we talked a little bit about non-inferiority trials before. I have a long write-up about them on my post. And it's just one of those trial designs that is so misunderstood, even by researchers. And I think that's what happened here. So this is a big multi-center, big trial, ICU, where they're trying to decrease antibiotic use. And so they have patients with sepsis, and they had a procalcitonin strategy, a CRP strategy, and then just standard of care. And in all those groups, you got little computer warnings, either based on your lab result or just a standard of care. And I'll say up front, so the CRP didn't do anything, but procalcitonin did decrease the amount of antibiotics you got by about 0.9 days. But the fatal flaw in this trial is non-inferiority. So their primary outcome was the decrease in antibiotics, but they're like, well, we got to make sure it's safe. And so our secondary or our safety outcome is mortality. And we'll do it as a non-inferiority design. And they picked it basically because of numbers. They'd already decided here's how big the trial is going to be. But they said the cutoff for non-inferiority was 5.4%, i.e. they designed the entire trial saying that as long as only 5.39% extra patients die, that's fine. It's non-inferior, no problem. Like, I don't know how that gets through a research ethics board. I don't get to know how that gets through design. I don't know how that gets through editorial. You can't design you probably should never use non-inferiority for mortality at all. Like, that's just not an acceptable outcome in general. But you definitely can't say, don't worry, only 5% more patients die. And it's a ridiculous design. And at the end of the day, they say it's non-inferior, but they're 1.5% more people died in the procalcitonin group. And so you can't really run the stats, but more people are dying using this strategy. And the online conversation, aside from me, was all like, oh, look at this. It decreases antibiotic use. Like, people are so pro this strategy, but It looks like more people die. Like, the number is higher, and the design is designed such that, don't worry, 5.39% more people can die, and that is fine. Like, people just need to understand non-inferiority designs. Like, I don't know that that's a true number. It probably isn't. Like, I don't know that procalcitonin does anything. I actually think if you're an ICU doctor and actually care about procalcitonin, this trial is almost certainly biased. And so I don't actually believe it decreases antibiotic use anyway. The way they messaged the standard care group received a message that looked identical to the high procalcitonin. But the point is, if you're going to design a non-inferiority trial, you don't do a power calculation and decide it. You have to decide what is a clinically relevant outcome. And maybe we would accept
0.
I don't know, but you can't have more people dying just to save 3 doses of ceftriaxone. Like, that's not a thing. We can do it in other things, like the non-inferiority trial on pneumothorax, because you're like, there is a bit of a trade-off. It wasn't mortality. It was, number of days before your chest x-ray was better. That's perfectly reasonable. But mortality should not have this kind of trial design. And so that's why I included it here, because it needed a rant. It's a little ridiculous.
Can I ask you, Justin, can you design non-inferiority trial and set the margin as 0? Is that something that's statistically possible to do? Or
No.
I don't know.
The stats would not work, because all what you're saying is I need to design a superiority trial, because you need to prove that you would be a slightly different than a superiority trial in that to be superior, you have to be above 0. That trial would be, I will be very happy with 0 and above. So you get a p-value of exactly 0.5 gets you a win, whereas in every other trial, it needs to be less than 0.5. That's the only difference in what you're asking. There are equivalence trials, which are a little bit different, but they run into the same problem. So an equivalence trial tries to prove that the two groups are the same. It still depends on the size of your 95% confidence intervals. And the problem with all these trials is you still need massive numbers to get those error bars small enough to really prove what you're trying to prove. And so in general, it's just not a good trial design. The way you get it, the reason you do a non-inferiority trial is because apparently the drug you're choosing or the treatment is better in some other way. What you should just be doing is proving that the drug's actually better. Like, forget about this whole trial design. We get all these new PPIs and they're like, look, it's non-inferior. And then you get another one that might be non-inferior. And maybe by the time the fourth one's on, they might be like dramatically different. They might be way worse. What you should just be doing is showing that your new product is actually better. Because otherwise, why the hell would anybody use it? That's the key.
I will say that a month or so ago, I joined Blue Sky. So I did FOAMed on Blue Sky, the new social media platform that all the medical education people tend to be going onto. And I got to say that my feed that comes through Blue Sky, about half of it is antibiotic stewardship. I don't know if that's just who I'm clicking on or whatever, but like, it seems like a really sexy topic at the moment. And I can see how, if you're a microbiologist or someone who lives and breathes antibiotic stewardship, and I'm all for antibiotic stewardship. Like, I love it. I get involved in our hospital, but yeah, there's antibiotic stewardship and then there's antibiotic stewardship. And I think getting the launch code right is probably the better use of antibiotic stewardship, like getting the right antibiotics into the patient up front, rather than, half a day less of antibiotics is probably not what's going to change the outcomes for the future of antibiotic use in the world.
Well, you just got to know that patients divide, right? In Emerge, I'm trying to teach my students all the time. Like, you get those ambulatory patients, and we should be testing less all the time. But give me a 95-year-old who's in a stretcher, and I don't care what test you order, because their pretest probability for something is so high that you just freaking order everything. In the hospital, cut back on the patients on the ward, but like, the ICU is not the place to be like, we need to cut down on antibiotics by a day and a half. Now, it's true that because they're so sick, we don't know what's going on. We throw a bunch, but like, it's not the ideal spot to be trying to cut things back. There are way better focuses. The ICU is unlikely to be the downfall of human civilization because of antibiotic resistance. It's going to be us putting them in freaking cows to get them a little bit meatier for market is really the problem. Like, let's not risk human lives in the ICU for the sake of a far off risk of resistance, would be my sake.
Good. All right. Should we move on to our final paper then?
Yeah, you gave me 12 hours to read something. I'm not sure how I would describe this. We're going back 1,000 years and really digging into how a plant should look like my organs, and therefore tell me that's how I'm to treat. I don't know anything about this signature theory, so you're gonna have to tell me what made you interested in this and why we started doing this.
I've actually been reading a fascinating book, which Carl Linnaeus, who was like the guy that invented basically the classification system of living things, and this is one of his interests back in the sort of 1700s. So that's what got me thinking about the medical side of this. So this paper, are you subscribed to Economic Botany? Is that one of the journals that's on your bedside, Justin?
I don't routinely get it. No, this might be the first paper.
No.
That's good. Yeah.
Okay, so it's Dr. Bennett. I think he's from Florida. In the title of the paper is Doctrine of Signatures, an explanation of medicinal plant discovery or dissemination of knowledge, ? This is a fascinating paper. So the doctrine of signatures is basically a really old concept, which basically is one of those sort of medieval ideas that the shape of some part of a plant tells you the therapeutic value of that plant. So, for example, liverwort is called liverwort because it sort of looks like a liver, the leaves of the liverwort, and therefore it can be used to treat liver or hepatic problems. And bloodroot has this red oozy stuff that oozes out of the roots, so it's called bloodroot, and they were using it to treat all sorts of blood disorders. And then obviously walnuts look like brains, so if you've got a problem with your brain, you need to eat walnuts. It's that sort of weird sort of backward way of thinking about how things work. And this was very common in the Middle Ages, and it was pretty much the standard of care. My personal favorite is a plant called saxifrage, and the root, as it grows in rocky outcrops, is able to split rocks because it's such a strong root, and so therefore they use it to treat renal stones. So, because it breaks stones with its roots, so it must work.
Makes sense. Yeah.
Now, this goes back millennia, so this has been doing since prehistoric peoples have been using this system to sort of work out what plant does what, and it's still used today in many sort of traditional herbalist parts of the world where we don't have access to modern medicine. Now, what happened in the Renaissance was that a lot of the emerging European scientific thinkers started poo-pooing this theory and saying this is clearly ridiculous. It doesn't make any sense. We're much smarter because we're European and we have all this access to science, and therefore they were sort of making fun of the ancients and saying this is just a ridiculous theory. And my favorite critique of the theory was Dr. Hahnemann, who in 1825 described the doctrine of signatures as the folly of the ancients, and he then went on to found the concept of homeopathy. So he was right on the money, that guy.
Because it was the exact opposite, right? I think it was like, like makes you worse or something like that. I don't know. It was the exact opposite. Like a liver. Yeah.
Looks like a liver, you got to use it for treating kidneys, or I don't know, or just a really little bit of it. Yeah. So on the surface, the doctrine of signatures obviously is ludicrous, and the resemblance of plants' surfaces, and the example that the author gives is the common purslane plant, which its roots look a bit like worms, and so traditional American healers use it for treating intestinal worm infestation. And so the reality is really interesting, though, because the Europeans basically had a giant attribution error in that they took this theory on face value and said, oh, well, just because something looks like something doesn't mean it fixes whatever ailment you have. But they've got it backwards because the ancients were much smarter than that, and that they'd tried this for hundreds of thousands of years, and Aboriginal people in Australia do the same. They use lots of different traditional medicines that they get from their own sort of native pharmacopoeia that's in the universe around them. And they weren't actually saying because it looks like this, it therefore fixes this. They were saying as a aide memoire, because they didn't write things down, it was a non-written language. They were saying, well, this plant that looks a bit like a liver, it seems to help people that have jaundice, so we'll keep giving it to them. And so it was backwards. They were just using it as an aide memoire, a way of passing on this knowledge through the generations. And then the Europeans got it completely backwards. And it's fascinating because it turns out that the purslane root is actually quite a good antihelminthic. So it's been used for thousands of years, and it seems to fix your problems in your gut. So there you go. Interesting theory.
I like the theory a lot, and I think one of my biggest pet peeves, and I fall prey to this all the time, and it actually blows my mind every time I think about it, but there's just no way the human brain has evolutionarily changed over the last 2,000 to 3,000 years. It's not long enough. So the IQ, like people were just as smart 2,000 years ago as we are now. We don't like to think about it. Like that's just not the way that even in like the Middle Ages, we think that they're still human beings. Like we are the exact same humans, different things passed down. So I think it is a bias that we tend to think, oh, these idiots. But I think that he puts forth this theory that it must have been an aide de memoire. But I think he proves that he's wrong because he goes through all this stuff. So he goes through and proves that there's absolutely no association. So he went through all. I think there's 80 plants that are shaped like a heart, and 17 are used medically, and only one actually does anything to the heart. And so he says, therefore, obviously, the old way of thinking is wrong. There's no association at all between the shape of the plant and the thing. But that also goes the other way. It disproves his theory. Things are clearly not named after what they're doing because there is no association at all between the shape and the plant. He proved it in his paper. It's just a random theory that he's thrown out as well. And I think there's two other things that show that. Number one, Google any of these plants. None of them look at all like any of the organs. Humans have pareidolia. We see dragons in clouds and a face on the moon. That's just what humans do. And so when we name things, we do things. But even more, these are European names that are assigned to the plants. They're not the names in the original language. If you go back and look at a bunch of these things, his theory is complete crap. It's easy to disprove because they aren't the names in the language that people were using, and it can't have been like if you say it's a lot like the squirrels in my backyard can never find their freaking nuts. They use memory aids because they're like, I buried it under that bush. But there's 27 bushes out there, and they go. So if you said, oh, it's the one that looks like a heart, and there's 78 plants that look like a fucking heart, then you're never going to be able to figure out which one it was. It clearly is not true either way. I think we just name things because we humans have a whimsy, and we name things whatever the hell we want. Why do we name a bird a tit? It just is what we do, man. It's like we have a thing. So I think both of them are a little bit ridiculous, and I enjoyed the chance to rant, but I think the bigger point of us judging people from 100, 1,000 years ago, or just from different cultures and assuming they're dumb is clearly wrong because they have the same brain, same physiology, and we do have a cultural bias. I think that part of the paper is entirely right. Everything else seemed wrong to me.
I do have a counterpoint to that though, Justin.
Yeah, good. I like it.
It is 2025, and after reading this paper, I went onto YouTube and looked up some influencers who are very well coiffed.
This is the counterpoint you think it is, but continue.
but there's influencers on YouTube right now who are using the original doctrine of signatures, and you can watch YouTube videos where like a 25-year-old health influencer brings out random clumps of garlic and says, well, this bit of garlic or this bit of ginger looks a bit like my butt. So if I drink this will tone my butt, or if I eat this will do it. And it's completely bizarre that people have not learned from history. And
so it's actually the opposite. I said they weren't any dumber than us, but actually you're entirely right. We are clearly dumber than we have ever been. You have access to the world's knowledge, and you're still that dumb. Yes, I 100% agree. Idiocracy, I assume you've seen that movie, is coming to pass. Sorry, Americans, but we're going to say you're leading the way. We're all in trouble. Is that where we're ending the podcast? I assume I can put clips on TikTok now because America's off TikTok, so we can make fun of them all we want as long as it's there. But I guess I'm still going to get it through the podcast. That's a problem.
Well,
sorry,
it's
America.
Where I am. It's inauguration day right now where I am, so I think TikTok will be back next week. So don't worry about it. Anyway, I think my point is that these poor people that were living in the rainforest and found plants that seemed to help them a bit. Great. They gave it a name and passed it down through their traditions. And then today we have, Google, and we have amazing resources and people that spend their whole careers studying organic compounds to work out what works. And we've got people making mAbs that actually do look a little bit like the problem that they're trying to solve. They're locking into keys and doing all sorts of amazing things. And yet we've still got people on TikTok who are pulling random bits of ginger out and saying, put this where the sun don't shine and it'll help you. So, it's just crazy that this is still a thing in 2025.
Yeah, the problem is it's just always the extreme, right? Because I do think it is absolutely amazing what the medical people of these cultures without science could accomplish. But I think most people discount them, which is too far one way, but the people who really lean in go way too far the other way and give them way too much credit. Like science has done a lot for us because I'm not discounting that person who worked in the Peruvian freaking Andes and did a whole bunch of stuff. I'm discounting the doctor in 1920. And as you heard on our podcast, I'm discounting the doctor in 2025 because a lot of people are scientifically illiterate and we still don't have, science has done a lot for us. And it's me criticizing your silly belief is not me criticizing you. It's just we go too far. Like science is very important, and I criticize my kind more than I criticize yours because we make the same mistakes because we all have the same weird, mushy hardware that's running us, and it's not very good. It's okay. It doesn't. I shouldn't say. I actually do think humans have done some pretty amazing things, but we have also, destroyed our planet. We might all be dead in a century. So who knows?
That's a charming, uplifting note to finish the podcast.
I'm very good at leading us out.
All right, mate. Well, that's the wrap for the first podcast of 2025. Look us up on the vodcast. If you want to go back and look at any resources, we'll leave links in the various blogs that we run. And this will be up on YouTube, so you can check it out there. Please leave comments because Justin loves answering YouTube comments. It's his favorite thing to do in his spare time. So go onto Justin's YouTube feed and have a look, and please let us know why we are wrong, because that's probably the most important thing about science, is knowing why you are wrong. Cool. All right, mate.
Cheers. It was a pleasure talking to you. Talk to you soon.